Selamat siang, selamat datang kepada seluruh peserta webinar series Caring in the Time of the Pandemic. Dalam hal ini kami akan membawakan ataupun mengantarkan tentang Cancer Center Strategies in Delivering Comprehensive Cancer Care, yang mana kalau kita berbicara tentang cancer care, artinya kita berbicara tentang kualitas suatu rumah sakit berhubungan dengan pelayanan kanker secara komprehensif. Yang mana hal ini juga berkaitan dengan fungsi Rumah Sakit Kanker Darmais yang telah ditunjuk sebagai pusat kanker nasional, yang nantinya akan melakukan mentoring atau pengampuan terhadap 14 rumah sakit rujukan nasional di Indonesia. Yang dalam hal ini kita mendapat dua pembicara dari internasional. Nanti pembicara pertama dari National Cancer Center Singapura dan kemudian dari National Cancer Center Jepang yang akan menyampaikan bagaimana pengalaman mereka dalam hal screening kanker dan juga bagaimana menangani kasus kanker di era pandemi COVID-19. Untuk membuka acara ini nanti akan dibuka oleh Profesor Dr. Abdul Qadir, PhD, spesialis THT, Kepala Leher Konsultan Mars, yang kemudian dilanjutkan dengan 3 pembicara yang juga nanti dihantarkan oleh Direktur Utama Rumah Sakit Kanker Darmais Pusat Kanker Nasional Indonesia. For our distinguished guests, thank you very much for joining us in this series of the Caring in the Time of Pandemic in the anniversary of Darmais Cancer Hospital National Cancer Center Indonesia. Then the opening remarks delivered by Profesor Dr. Abdul Qadir, PhD, Specialist ENT, Mars, as a Deputy Minister of Health Services, Directorate General of Health Service, Ministry of Health Indonesia. Untuk menyingkat waktu, kami persilahkan pada Profesor Dr. Abdul Qadir, PhD, Spesialis THT, Kepala Leher Konsultan Mars, untuk membuka acara ini sekaligus menyampaikan keynote speaker dalam acara ini. Kami persilahkan, Prof.
Oke, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera untuk kita semua. Yang saya hormati our invited speakers, Professor William Wan from Singapore National Cancer Center, Medical Director, and also is our invited speaker from Japan, Mr. Tomohiro Matsuda Sensei from National Cancer Center Japan. Teman-teman Direktur Utama, para direksi, Dr. Evelyn, serta para Direktur Rumah Sakit seluruh Indonesia yang kami hormati. Pertama-tama tentunya marilah kita bersama-sama memanjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala atas limpahan rahmat dan hidayah yang diberikan kepada kita semua, sehingga hari ini kita masih sempat ketemu di dalam acara yang diselenggarakan oleh Pusat Kanker Nasional Rumah Sakit Kanker Darmais dengan tema Cancer Center Strategies in Delivering Comprehensive Cancer Care. Saya kira ini sesuatu yang sangat bagus sekali buat kita semua. Dan juga pada kesempatan ini saya mengucapkan dirgahayu dan selamat ulang tahun Rumah Sakit Kanker Darmais yang ke-27. Semoga Rumah Sakit Darmais sebagai Pusat Kanker Nasional Indonesia masih tim terdepan dalam kiprahnya dan dalam penanggulangan kanker nasional, serta dapat mensejarkan diri dengan National Cancer Center level di Asia. Bapak-bapak dan ibu-ibu sekalian, saat ini kita semua sedang menghadapi pandemi COVID-19 dan tentunya terjadi tidak cuma di Indonesia tapi di seluruh dunia. Dan tentunya menuntut kita semua untuk berperan aktif untuk bisa melawan dan menghentikan pandemi ini. Bagaimana kita bisa memperkecil angka kematian akibat COVID-19 serta bagaimana meningkatkan angka kesembuhan. Oleh karena itulah saya ucapkan terima kasih kepada teman-teman sekalian yang telah bekerja keras dan kerja cerdas dari semua jajaran kesehatan, khususnya bekerja di rumah sakit, sehingga sebagai garda terdepan, sehingga dengan demikian maka kita banyak berperan dalam penanganan pandemi COVID-19. Bapak-bapak dan ibu-ibu sekalian, National Cancer Center in Asia dalam hal ini adalah dibentuk dari beberapa negara dalam perkumpulan disebut sebagai ANCA atau Asian National Cancer Center Alliance, di mana 14 anggota ANCA tersebut yaitu adalah Pusat Kanker Nasional yang ada di Bangladesh, China, India, Indonesia, Jepang, Korea, Malaysia, Mongolia, Nepal, Pakistan, dan Singapura, serta Thailand, Turki, dan Vietnam. Pada Oktober 2018 yang lalu, bertepatan dengan hari ulang tahun Rumah Sakit Kanker Darmais yang ke-25, Indonesia menjadi tuan rumah pertemuan angka ke-7. Alhamdulillah saya turut aktif dalam acara tersebut dan turut bangga karena Indonesia dapat tampil dan menjadi tuan rumah pertemuan internasional. Saya sangat mendukung kegiatan angka ini dan semoga makin berperan positif dan makin etis dalam penanggulangan kanker di dunia internasional. Saya sangat berharap adanya forum angka ini dapat menjadi ajang saling berbagi dan bertukar pengalaman di antara negara anggota angka dalam penanggulangan kanker secara komprehensif, mengembangkan pelayanan kanker paripurna. Demikian juga diharapkan adanya pendidikan kanker yang berkelanjutan dan penelitian di bidang kanker yang spesifik, ras Asia, maupun penyediaan data beban kanker Asia. Terbinanya jaring yang baik, kesetaraan institusi, serta kerjasama saling menguntungkan antara NCC anggota angka merupakan bakal utama dalam mengembangkan strategi penanggulangan kanker komprehensif di tingkat Asia. Perlunya promosi dan preventif, program deteksi dini, diagnostik dan terapi, palliative care sampai pada pencatatan registrasi kanker merupakan program yang utama dalam penanggulangan kanker yang berlaku global termasuk Indonesia. Bapak-bapak dan ibu-ibu sekalian, berdasarkan data BPJS Kesehatan, beban biaya kanker terus meningkat dari tahun ke tahun. Kanker menempati urutan ketiga setelah ginjal, jantung, dan stroke dalam pembiayaan kesehatan secara nasional. Pada tahun 2014, kanker menghabiskan anggaran sekitar 1,9 triliun rupiah. Kemudian meningkat pada tahun 2015 sebesar 2,5 triliun dan pada tahun 2018 ini menghabiskan anggaran 3,1 triliun rupiah. Di Indonesia, kanker adalah masalah kesehatan masyarakat yang utama, bukan hanya karena tingginya prevalensi, tetapi juga karena beban biaya pengobatan yang tinggi. Berdasarkan laporan Global Kan 2018, kanker payudara adalah kanker yang paling umum di Indonesia dengan tingkat kejadian 42,1 per 100.000 penduduk, dengan kematian 17 per 100.000 penduduk. Diikuti oleh kanker serviks, kemudian dengan tingkat kematian 23,4 per 100.000 penduduk dan tingkat kejadian 23,4 per 100.000 penduduk dan kematian 13,9 per 100.000 penduduk. Bapak-bapak dan ibu sekalian, sekira penanggulangan kanker komprehensif harus serius dengan kegiatan-kegiatan promosi terus-menerus tentang pentingnya masyarakat hidup sehat. Sangat diharapkan dengan germas ini, maka penurunan pembiayaan akibat kanker juga akan berkurang. Yang tidak kalah pentingnya adalah penataan sistem rujukan kanker, sehingga kasus-kasus kanker dapat ditemukan dalam stadium dini. Saya sangat mendukung usulan Pusat Kanker Nasional Rumah Sakit Darmais dalam menyusun stratifikasi Pusat Kanker Nasional dan Pusat Kanker Terpadu sebagai salah satu upaya menata sistem rujukan kanker dan menjadikan penanganan kanker dapat dirasakan oleh seluruh masyarakat di Indonesia dengan kualitas pelayanan yang terstandarisasi dengan baik. Saya yakin upaya menata sistem rujukan yang baik akan menjadi daya ungkit tersendiri dalam menurunkan pembiayaan akibat kanker dan meratakan pelayanan kesehatan. Hadirin yang saya hormati, saya berharap webinar ini dapat memberikan gambaran bagaimana pelayanan kanker komprehensif yang ada di Indonesia dibandingkan dengan tetangga kita di Singapura dan Jepang. Lesson learned dari National Cancer Control Program di kedua negara ini akan memperkaya kita bagaimana menyusun program penanggulangan kanker yang baik di Indonesia. Saya harapkan semoga webinar ini dapat bermanfaat bagi kita semua dan dengan ucapan Bismillahirrahmanirrahim, maka dengan ini acara webinar dalam rangka Hari Ulang Tahun Rumah Sakit Kanker Darmais yang ke-27 saya nyatakan dibuka dengan resmi. Terima kasih. Dan special for our invited speaker, I want to invite you, all of you, to sharing your knowledge, to share your experience to our colleagues in Indonesia. As you know, maybe if we compare between Indonesia and Japan or between Indonesia and Singapore, we have to learn more from you, from both of you. And that is why from this meeting, we hope you can sharing your knowledge to our colleagues in Indonesia. Thank you for your participation dan terima kasih sekali lagi kepada teman-teman sekalian. Selamat mengikuti webinar ini dan terakhir saya akan bacakan satu pantun. Pantunnya seperti ini. Ini untuk Evelyn ini. Rambutan. Jangan lupa membeli tomat. Juga jaga selalu kesehatan supaya kanker tidak mendekat. Saya kira itu harapan saya terakhir. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih atas pembukaan dan keynote speaker dari Profesor Dr. Abdul Qadir PhD, spesialis THT Kepala Leher Konsultan MARS, sebagai Deputy Minister of Health Services, Directorate General of Health Services, Ministry of Health Indonesia. Sekarang kita masuk ke dalam presentasi selanjutnya yang akan disampaikan oleh Direktur Utama Rumah Sakit Kanker Darmais Pusat Kanker Nasional. Namun demikian, kami akan membacakan terlebih dahulu kurikulum kita beliau, yaitu sebagai Presiden Director ataupun sebagai Direktur Utama Rumah Sakit Kanker Nasional, Pusat Kanker Nasional 2018-2020 sampai 5 tahun ke depan. Dan sebelumnya beliau juga menjabat sebagai Direktur Umum dan juga bertugas di Kementerian Kesehatan, sebelum juga pernah bertugas di Cipto Mangunkusumo.
Halo Bu.
Sebelum menyampaikan, kami akan meminta kepada seluruh peserta ataupun kepada direktur
Belum launching Bude, ini kelamaan Bude.
dinas
Di kantor Bude.
untuk dapat menyampaikan pertanyaan melalui ruang chat yang ada. Kami akan tetap memantau ruang chat untuk berbagai pertanyaan yang disampaikan. Terima kasih. Kami akan mengundang kepada Presiden Direktur Rumah Sakit Kanker Darmais Pusat Kanker Nasional Indonesia untuk menyampaikan Comprehensive Cancer Care Delivery in Indonesia. Waktu dan tempat kami persilahkan.
Baik, terima kasih Dr. Evelyn. Bapak Ibu sekalian yang saya hormati, pertama Profesor Abdul Qadir, kemudian invited speaker Dr. Tomohiro and Profesor William. Thank you very much. Dan tentunya kepada para peserta di sini ada dari Direktur Utama Rumah Sakit atau Direksi Rumah Sakit dan juga partisipan lainnya. Terima kasih atas partisipasinya di webinar ini dalam rangka di hari ulang tahun Rumah Sakit Kanker Darmais yang ke-27. Berbeda dengan tahun sebelumnya, hari ini dilaksanakan dengan lebih sederhana, tetapi justru cakupannya meluas sampai kemana-mana. Mudah-mudahan ini bisa menjadi manfaat untuk kita semua. Excuse for Dr. Tomohiro and Professor William. My presentation, my slide is delivered in English language, but I will deliver this in Bahasa Indonesia. Ini adalah improving cancer care outcomes in Indonesia. Jadi bagaimana kita akan mengembangkan atau menguatkan kembali pelayanan kanker di Indonesia. Slide. Kalau kita lihat, ini adalah data cancer burden di Indonesia, data dari The Economist, yaitu suatu lembaga data yang menilai kesiapan dari suatu negara terhadap pelayanan kanker di negara tersebut. Kalau kita lihat sebelah kiri, overall score atau nilai total yang dicapai oleh Indonesia itu masih di bawah rata-rata. Kita berangkat 57,4, sedangkan rata-ratanya 65,5. Overall score ini didapat dari apa? Yang pertama adalah policy dan planning, kebijakan dan perencanaan. Indonesia masih menduduki nomor ke-7 dan itu masih di bawah rata-rata. Kemudian juga bagaimana pelayanan itu diberikan atau sampai kepada masyarakat. Indonesia masih menduduki nomor 6 dengan skor 53, masih di bawah 60. Dan terakhir adalah bagaimana health system dan regulasi yang ada di negara kita masih dianggap nomor 7. Memang kita masih di Malaysia dan Thailand, di beberapa hal kita lebih tinggi dari negara lain, tetapi secara rata-rata Indonesia masih perlu penguatan lagi di dalam penyelenggaraan atau pelayanan kanker di Indonesia. Slide. Ini adalah slide yang menggambarkan sebetulnya Kementerian Kesehatan itu memiliki tugas untuk membuat strategic plan untuk Kementerian Kesehatan. Kemudian ada juga tugas untuk membuat rencana induk nasional serta tugas stratifikasi layanan kanker yang tadi disampaikan oleh Profesor Abdul Qadir, serta bagaimana penguatan terhadap sistem rujukan di 14 rumah sakit nasional, 20 provinsi, dan 110 regional. Ada 144 yang sudah ditunjuk. Dalam konteks Comprehensive Cancer Control Program di Indonesia, tugas dari NCC adalah bagaimana mensupport atau mendukung Kementerian Kesehatan ini. Kita punya tugas untuk menjamin bagaimana sistem rujukan kanker di Indonesia, bagaimana Cancer Control Program itu dilaksanakan di Indonesia, dan bagaimana melakukan pembinaan atau mentoring lah untuk pelayanan kanker atau jejaring pelayanan kanker di Indonesia. Karena negara kita sangat luas, sehingga kita harus punya sistem yang diikuti oleh semua, sehingga ini bisa berjalan dengan baik. Yang akan kita lakukan sebenarnya kita akan mencontoh juga rumah sakit yang lebih senior tentunya, seperti RSCM, Rumah Sakit Cipto Mangunkusumo, dan juga Rumah Sakit Jantung Harapan Kita yang sudah lebih dahulu memiliki sistem rujukan yang lebih baik. Slide. Ya. Kenapa sih kita membutuhkan penguatan pelayanan kanker di Indonesia? Kalau kita lihat yang pertama, tentunya setiap penduduk di Indonesia dimanapun berada, itu harus memiliki memiliki hak yang sama untuk mendapatkan akses dan layanan kanker yang bermutu. Kemudian, tapi kita dihadapkan juga dengan distribusi dari tenaga kesehatan, termasuk dokter, dan perawat dan spesialis yang belum merata di seluruh Indonesia. Kita juga masih punya persoalan atau tantangan dalam distribusi medical equipment. Ya, alat-alat kesehatan masih belum merata juga di beberapa fasilitas pelayanan kesehatan. Kita juga masih perlu penguatan dalam standar-standar pelayanan dan juga perkembangan alat kesehatan yang sedemikian cepatnya setiap tahun akan berganti teknologi, sehingga ini menimbulkan risiko bahwa kita selalu berada pada posisi yang kalah maju dibandingkan dengan kecepatan dari teknologi ini, khususnya juga di daerah-daerah yang terpencil misalnya. Kita lihat ke atas kanan ada ketersediaan fasilitas pelayanan kanker masih berada di kota-kota besar. Kita dihadapkan pada tantangan geografik yang sedemikian rupa sehingga sistem rujukan khususnya di daerah-daerah yang jauh dari kota besar itu menjadi persoalan untuk penanganan kanker. Kita tentunya dari semua ini membutuhkan comprehensive cancer care di seluruh Indonesia. Bagaimana caranya? Nah, di pandemi ini mengajarkan kepada kita untuk masuk ke dalam budaya baru di mana kita memanfaatkan teknologi seperti daring atau kita kenal dengan virtual meeting yang rasa-rasanya ini bisa menjadi jembatan untuk bisa menerobos kekurangan-kekurangan atau memperkuat apa yang sudah kita lakukan selama ini. Slide. Rumah Sakit Kanker Darmais sendiri telah memiliki rencana jangka panjang sebetulnya, 25 tahun. Ini digagas oleh pendahulu Rumah Sakit Kanker Darmais termasuk Profesor Abdul Qadir, di mana kalau kita lihat kita sekarang masuk pada periode 2020 sampai 2024, di situ tertulis bahwa ada tugas Rumah Sakit Kanker Darmais untuk membangun atau mengembangkan pelayanan kanker network, baik itu nasional maupun internasional level. Jadi ini adalah bagian dari upaya-upaya kita dini awal untuk memulai apa yang namanya jejaring pelayanan kanker yang bersifat nasional dan internasional. Di dalam rencana jangka panjang ini, memang Rumah Sakit Kanker Darmais sejak tahun 2017 telah ditunjuk sebagai National Cancer Center, Ini secara resmi ditunjuk oleh Menteri Kesehatan, sehingga kita mempunyai tugas yang berat, tetapi saya yakin karena dukungan dari teman-teman semua rumah sakit rujukan, ini semua pasti bisa akan terlaksana. Di dalamnya tentunya kita akan mengembangkan bersama-sama tentang comprehensive care center atau pelayanan, demikian juga dengan pelatihan, pendidikan dan pelatihan, kemudian bagaimana data dan cancer research ini dilakukan. Ini sangat penting karena data kita ini dipantau oleh internasional atau dunia. Dan ini harus mencakup paling tidak 10% dari populasi yang ada di Indonesia sehingga ini bisa dianggap valid data yang dikirimkan ke dunia. Kemudian juga hubungan dengan jejaring-jejaring dengan dengan rumah sakit ataupun puskesmas, dan juga secara internasional kita sudah menjalin kerjasama dengan ANKA dan organisasi-organisasi dunia lainnya. Slide. Nah, apa sih yang akan kita lakukan dengan Comprehensive Cancer Control Program? Ini mungkin menjadi pemahaman untuk kita semua, bahwa mengembangkan pelayanan kanker di Indonesia secara komprehensif itu bukan tugas dari Rumah Sakit Kanker Darmais NCC semata, tetapi juga melibatkan banyak sekali sektor-sektor lain yang terkait. Ambil contoh misalnya di sebelah kiri kita tentunya peran dari Kementerian Kesehatan sangat kami harapkan, kemudian juga kementerian lainnya seperti Bappenas, Kementerian Keuangan, Kemendagri, Kemensos, dan lain-lain. Tentunya NCC yang diberi tugas akan memantau atau mengawal ini dengan terus-menerus. Kemudian regional government atau pemerintah daerah. Kemudian ada lagi dinas kesehatan, ada rumah sakit rujukan, health facilities, ya. Kemudian organisasi profesi, dan juga tidak lupa LSM dan juga penjamin. LSM seperti misalnya YKPI atau YOI itu memiliki jejaring di daerah sehingga bisa menjadi kolaborasi yang baik. Mengapa semua ini terlibat? Karena yang akan kita propose untuk menjadi Comprehensive Cancer Control Program adalah 7 hal atau 7 item yang dikembangkan oleh WHO atau WHO. Mulai dari promotion dan prevention atau promosi dan pencegahan, kemudian early deteksi. Masih banyak kasus-kasus yang datang ke rumah sakit dan saya yakin juga masih banyak pasien yang datang ke rumah sakit rujukan itu datang dalam kondisi stadium 3 dan 4. Ini membuktikan bahwa early detection itu belum berjalan dengan baik. Padahal kita mungkin sudah sekitar 30 tahun program early detection ini dijalankan. Artinya ada sesuatu yang harus kita perbaiki, baik dari promotion and prevention sampai dengan early detection ini. Kemudian tentunya ada diagnostik seperti PA, PK, radiologi, ini juga menjadi perhatian bagaimana sih koordinasi antara Rumah Sakit Kanker Darmais dan rumah sakit rujukan lainnya. Kemudian health services yang meliputi kemoterapi atau pelayanan yang meliputi kemoterapi, pembedahan dan juga radioterapi, kemudian surveillance, ini cancer registry, ini jadi PR besar karena memang kita selalu dipantau dan Dr. Evelyn menggawangi ini, mudah-mudahan sukses ya dok ya. Kemudian research, penelitian ini utamanya terkait dengan kanker, karena kita luas dan punya kekasan Indonesia, tentunya ini sangat bisa dikembangkan. Dan terakhir tentunya rehabilitasi dan palliative care dan hospice home care ini juga harus dikembangkan bersama-sama. Apa yang bisa kita lakukan yaitu kita harus terus-menerus melakukan transfer of knowledge, baik itu dari luar negeri ataupun dari rumah sakit rujukan yang sudah advance ataupun pengalaman-pengalaman rumah sakit kanker Darmais ini dalam bentuk suatu mentoring. Slide. Nah, ini adalah usulan sistem rujukan untuk kanker. Agak sedikit berbeda dengan sistem rujukan yang ada. Kita perlu memastikan bahwa sarana prasarana ataupun SDM yang ada di sistem rujukan ini sudah terpenuhi agar comprehensive cancer care ini bisa berjalan dengan baik. kita mengenal ada strata 1, strata 2, dan strata 3, di mana masing-masing itu memiliki standar dari sarana prasarana dan SDM. Apabila ini terpenuhi, maka baru sistem rujukan ini dapat berjalan dengan baik. Slide. Nah, yang penting lagi yang menjadi perhatian dari Rumah Sakit Kanker Darmais adalah bagaimana dengan pembiayaan dari semua itu. Karena untuk bisa memenuhi sarana prasarana dan SDM tentunya dibutuhkan penganggaran yang terstruktur begitu. Dari sisi finansial, kita tentunya akan mengumpulkan data terkait dengan SDM, dari ASPAK kita analisa, kemudian alat-alat, sarana prasarana, standar WHO-nya seperti apa, dan standar stratifikasi rumah sakit kanker. Dari data-data ini kita bisa mengumpulkan yang namanya gap analysis, yang kemudian bisa kita dorong kepada Kementerian Kesehatan untuk menjadi rencana induk nasional yang tentunya terkait dengan anggaran. Rencana induk nasional ini harus diadvokasi juga kepada Bappenas sebagai perencana nasional dan juga Kementerian Keuangan, sehingga nanti ke depannya akan dialokasikan anggaran yang cukup, baik itu di pusat dan daerah melalui DAK misalnya, sehingga pemenuhan standar sarana prasarana dan SDM itu bisa terpenuhi. Dan demikian seterusnya siklus ini berjalan demikian. Slide. Nah, kita memanfaatkan situasi saat ini, bagaimana komunikasi ini bisa terus-menerus berjalan, karena suatu program akan berhasil, saya yakini apabila komunikasi itu dilakukan terus-menerus. Jadi ini adalah suatu sistem mentoring yang berlandaskan sebenarnya webinar biasa yang biasa kita kenal, tetapi program-programnya harus lebih terstruktur lagi. Kalau kita lihat ada referral hospital di bawah, kemudian dengan sistem mentoring ini kita bisa saling bertukar pengalaman, kita bisa bertukar knowledge begitu, sehingga nanti dikaitkan dengan ASPAK dan data-data yang ada, bisa kita usulkan suatu National Framework for Cancer Care. Nah, dari National Framework ini apabila sudah disepakati nanti, maka akan terciptalah yang namanya National Comprehensive Cancer Care. Nah, peran Rumah Sakit Kanker Darmais tentunya sebagai NCC akan mengawal ini. Mohon izin dari Bapak Ibu, Direktur Utama, kalau nanti Rumah Sakit Kanker Darmais akan mengganggu terhadap program-program ini, mohon kami disupport agar program Kementerian Kesehatan dalam kaitannya pengembangan layanan kanker ini bisa terlaksana. Slide terakhir saya kira adalah summary dari semuanya, bahwa di masa mendatang itu sangat besar akan terjadi peningkatan dari penyakit kanker di masa mendatang. Sehingga penguatan dari comprehensive cancer care ini harus menjadi salah satu prioritas nasional. Yang kedua, kita perlu strategi yang bersifat nasional, dan ini sangat krusial untuk mengatasi tantangan-tantangan dalam pelayanan kanker di seluruh Indonesia yang secara komprehensif. Rumah Sakit Kanker Darmais punya kewajiban atau tanggung jawab untuk mendukung Kementerian Kesehatan dalam mengembangkan NCCP atau National Cancer Care Program. Tahap pertamanya tentunya kami akan mengkompilasi data, menganalisa data untuk situasi penanganan kanker di Indonesia, sehingga ini bisa menjadi bahan-bahan untuk kebijakan di Kementerian Kesehatan. Tentunya yang keempat adalah kolaborasi atau dukungan dari semua stakeholder, dari kementerian dan juga dari teman-teman dari rumah sakit rujukan, rumah sakit Cipto yang paling jauh di mana ini? Sekarang ada di Ambon ya, juga termasuk adalah sangat kami butuhkan untuk meyakinkan bahwa program ini dapat atau strategi ini dapat diimplementasikan dengan sukses. Yang terakhir, SIMEKARS atau Sistem Mentoring Kanker di Rumah Sakit. Ini adalah suatu program yang biasa sebetulnya, tetapi Ini merupakan jembatan penghubung komunikasi antara NCC, National Cancer Center Darmais, dengan Kementerian Kesehatan dan juga rumah sakit untuk memungkinkan pertukaran pengetahuan dan kemampuan untuk mendukung terciptanya comprehensive care di Indonesia. Jadi dari kegiatan yang sederhana ini di usia Rumah Sakit Kanker Darmais yang ke-27, kami mencoba untuk memulai suatu program pengembangan layanan kanker yang dimulai step by step sampai dengan tahun nanti 2024. Mohon dukungan semuanya dengan segala kerendahan hati. Tentunya program ini bukan program Rumah Sakit Kanker Darmais saja, tetapi kebutuhan untuk masyarakat luas, tentunya pasien yang membutuhkan pelayanan kanker dimanapun di Indonesia. Terima kasih atas perhatiannya. Mohon maaf apabila dalam penyampaian ini terdapat kekurangan-kekurangan, semua dari saya. Mohon maaf sekali lagi dan terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih kami ucapkan kepada Presiden Direktur Rumah Sakit Kanker Darmais, Pusat Kanker Nasional Indonesia yang telah menyampaikan presentasi yang begitu lengkap, dan kami sangat berharap kisah sukses dari rencana yang akan dilakukan merupakan kisah sukses untuk bangsa Indonesia, terutama dalam penanggulangan kanker nasional yang bersifat komprehensif, baik itu di tingkat rumah sakit sampai di tingkat puskesmas, sehingga pengenalan akan pelayanan kanker ini bisa diketahui merata di tingkat populasi. Kami mengucapkan terima kasih kepada peserta yang terus hadir dalam acara ini, dan kami berharap ada pertanyaan yang bisa disampaikan di ruang chat. Now we would like to invite our distinguished guest, the second speaker, Profesor William Wang. Kami akan membacakan kurikulum vitae beliau. Profesor William Wang as a Medical Director of National Cancer Center Singapore. Dan beliau bekerja dari sejak tahun 1997, yang nanti akan menyampaikan tentang continuing comprehensive cancer care in the COVID-19 crisis. For Professor William Wang, the time is yours.
Thank you very much for the introduction. It's really my pleasure. Professor Abdul Qadir, Dr. Soeko, colleagues from NCC Damai, congratulations on your 27th anniversary. It's really a tremendous milestone, and I'm so happy to be here with you today. It's now about 3:30 p.m. Singapore time. I planned my talk for 20 minutes, so it will take us nearly to the end of the hour, and I hope that you will continue to be able to stay on for my next speaker, Dr. Matsuda. So today, I will share with you on continuing comprehensive cancer care during this COVID-19 crisis. I am speaking on behalf of the perspective of the National Cancer Center of Singapore, and I'm primarily a hematologist, and that's my area of specialty is in bone marrow transplantation. But for today, I will speak on behalf of our perspective on comprehensive cancer care during the COVID-19 crisis. The National Cancer Center of Singapore sees about 60 to 65% of public sector cancer patients in Singapore and 55% of all cancer cases in Singapore. We have multiple specialties within our cancer center, including surgery, surgical oncology, oncologic imaging, medical oncology, radiation oncology, supportive and palliative care, oncologic nursing, as well as pharmacy, counseling support. We have regular tumor boards and a lot of research happening within our center. Multidisciplinary tumor boards are extremely important, and on the left you can see some of the tumor boards that are conducted every week within the cancer center, and these are the usual attendees for the multidisciplinary tumor boards, whether they are medical oncologists, radiation oncologists, and so on. These tumor boards are extremely important because it allows us to tap on the wisdom of our peers with other skill sets. For example, as a medical oncologist or hemato-oncologist, I might not be sometimes so aware of some things for which the pharmacist might want to share with me, of which the nurses might want to share with me pertaining to the patient. It's also important for us to have evidence-based medicine. So we base our practice on evidence rather than eminence-based medicine, so that in eminence-based medicine, sometimes we listen to the biggest professor in the room. But tumor boards compel us to base our practice on evidence-based medicine. It is also a legal requirement for us to have tumor boards in Singapore, and it's also needed that you have to attend a certain number of tumor boards for maintenance of our practicing certificate. Within the National Cancer Center, the Division of Medical Oncology is our largest division with 52 medical oncology specialists. It serves Singapore and the region. And in it, we have various key initiatives on the left side, including things like targeted therapy, cellular therapy, and many others. And some key areas of emphasis on the right side, including women's cancer, lymphoma, sarcoma and rare malignancies, as well as some others. There are also some research programs of particular interest, but these are just a few that I've listed. Our Division of Surgery and Surgical Oncology has newly been reformed. We used to have a Division of Surgical Oncology that is just our cancer center surgeons, which was totals about 14 specialists. But this is now combined with the Singapore General Hospital Division of Surgery to give us a total of about 136 specialists stretching across all the disciplines of surgery in cancer. So many aspects of surgical oncology, whether they are colorectal surgery, breast surgery, allowed us the formation of new departments like sarcoma, peritoneal, and rare tumor, called our sprinted department, for example. And formation of new departments like head and neck surgery, and so on. This allows us to share resources with the Singapore General Hospital and allows us to work very intimately as a continuum of care throughout this practice. The Radiation Oncology Department is the largest of 4 radiation facilities in Singapore, with our specialists seeing about 3,000 new patients a year. It serves as a referral facility center for radiation treatment, not only for Singapore, but also for the East Asian region. And these are some of the key initiatives on the right side, including many things like tomotherapy, volumetric arc therapy, 3D internal radiation brachytherapy, and we have an upcoming proton therapy center as well. For oncologic imaging, we provide a wide range of medical imaging services, and we currently have a totally filmless environment through our picture archival and communication system. So almost no films are printed right now, and all images are viewed at the consultation room via personal computers, and also printed only on patients' request. These are some of the key initiatives in our oncologic imaging department, including teleradiology services. In our supportive and palliative care department was the first standalone department of palliative care that was created ago. It was recently reorganized into Division of Supportive and Palliative Care to recognize that much of the care is needed not only when a patient is at the palliative stage, but also in the very early stages of cancer care. Some of the key initiatives include the development of specialty in palliative care, extensive involvement in palliative care education, collaboration with the Lien Center for Palliative Care, and heading the Asia Pacific Hospice Network. This slide is also to remind us that a key component in clinical quality and delivering of a comprehensive cancer services is not just in the clinicians, but also in people on the operation side and the service side. So we rely a great deal on our people in operations to deliver lean operations, QI projects, increase access, increase affordability, people on the service side to help us reduce waiting time, to focus on population health and community care, in order to combine all these into high quality care to deliver to the patient. And right now, the National Cancer Center Singapore sees itself not just as a singular center, but we stretch our services across multiple centers within the SingHealth cluster, including the Singapore General Hospital, Changi General Hospital, the Sengkang Hospital, and many others. So we serve as part of this continuum of care, but we provide the thought leadership in this to develop cluster-wide strategy in conjunction with population health, standardized reporting and wait times, We develop guidelines, protocols, and pathways throughout this continuum of care, provide leadership in survivorship, and as well as coordinate many aspects, including palliative care and right sizing of patients. So this creates a continuum of care to address prevention, diagnosis, treatment, and survivorship. This allows us to provide high-quality, comprehensive cancer care in the SingHealth cluster, characterized by state-of-the-art clinical medicine, which includes evidence-based and sophisticated therapies targeted to patients' tumor and biological characteristics, and an approach to care that is attentive to the spectrum of the patient's needs, as well as a system solution to achieve patient-centered care delivery goals. And the service lines serve as catalysts to academic medicine and research. Now, moving forward, our Cancer Center has been also spearheading the development of a national cancer plan. This slide is about a year old because we were almost ready with our national cancer plan, except due to COVID-19 and a lot of the people in the Ministry of Health being very, very busy during this period because of COVID-19. So it looks like we will have the plan out in 2022 as opposed to this year. But many aspects of the cancer plan, which is too long to show here, have been crafted. We are also looking forward to a new National Cancer Center, which is right next to our current Cancer Center. It will be a new 28-story building, which will allow us to have a National Cell Therapy Center, and as well as proton therapy, and many other new innovations to allow us to deliver best care for our patients. Then, of course, many of us know that COVID-19 struck us early this year. It struck all of us. And it's particularly important to cancer patients for a few reasons. And I'll show you two publications for which one of our oncologists collaborated very closely with the hospital in Wuhan to be able to help them analyze the outcomes pertaining to COVID-19. And I show why this is important to cancer patients. This is our radiation oncologist, Melvin, who collaborated with his colleagues in Wuhan, China. And he found that out of 1,500 hospitalized patients, the incidence of these patients cancer patients contracting COVID-19 was about 0.8% versus the community rate of about 0.4%. This means that cancer patients have a 2 times higher rate than the community of 0.8%. What about the type of cancer? In terms of type of cancer, we found that lung cancer patients have a 2 times higher rate compared to other cancer patients. We have a 1.8% rate of contracting COVID-19 versus the 0.8 for other cancer patients. So it's about 2 times higher. What if you are an older lung cancer patient? Then there is even 2 times of that. And older age, more than 60, has 2 times higher risk than the younger patients. Furthermore, this is just the risk of catching COVID-19. What about, and this is despite some protective measures that are already in place in Wuhan during that period of time. This is another collaborative publication that Melvin did with Wuhan. And he found that patients on active treatment did a lot worse than patients who are just on regular follow-up. So as you can see, patients who are on therapy, whether systemic or non-systemic, had a much higher risk of severe COVID-19 and also a higher chance of not surviving COVID-19, indicating that active cancer treatment increases risk of severity and death. So COVID-19 is extremely important to cancer patients and cancer centers. So because of the importance of this for our cancer patients who are immunocompromised, we immediately set out to develop and create a NCCS Disease Outbreak Response Task Force called the DORS Task Force. We had an early mobilization of this DORS Task Force with daily huddles, weekly head of department meetings, twice a week meetings with the cluster task force, and collective decision making from all parts, with division into epidemiology, infection control, medical operations, human resource, and communication. And the reason why we could roll this out so quickly, I reflected as I looked on my bookshelf, and on my bookshelf was this folder titled the Disease Outbreak Response Manual, which was crafted in 2015. So it was a playbook that was ready to be rolled out. So once the crisis struck, we just opened the playbook and started in instituting all the measures. So important part in preparation is the word pre in preparation. It has to be done before the crisis itself. This allowed us to change our physical infrastructure very quickly in terms of creation of fever clinics, triage and screening. And this happened almost overnight. And this is one of the consult rooms within our fever clinic. And what we did is we converted the cafe outside our cancer center because the vendor was not going to come to the cafe anymore. So we converted it to a fever clinic. We created screeners, and you see a 30-degree kind of angle here, which allows good separation between the tables. It's kind of a design philosophy. Temporary rain shelters were also created, and holding areas for patients with symptoms as well. Safe management was instituted for patients and visitors as well as staff. And you can see separation boxes for patients to stand within a particular distance, and also the number of patients that could be inside the lift. Even for staff, separation between the chairs to ensure at least 1 meter apart. And then waiting areas in the clinic had signages. Chairs were marked with do not sit on some of the chairs. And some of the sinks were also marked with do not use some of these sinks. We can see acrylic screens being created on some of the areas in order to allow staff to be able to eat here during lunchtime without spreading infections to each other. And the labor tables are reasonably long, but still the acrylic screens help further. Business continuity plans were rolled out almost immediately, incorporating work from home, split teams, staggered hours arrangements. External deployment of our staff was also needed to support our nation's efforts. So many of our staff were deployed to the foreign worker dormitories, to the various community care facilities and other areas. We had simulation of end-to-end workflows. We had to ensure stable network connectivity because suddenly a lot of people were using the internet due to the inability to travel. And so we had to ensure stable network connectivity for our patients and our staff. A very important part of managing our crisis was logistics and supply management. And we had to develop deep contingency plans with increased scope. We had to build and review critical supply stockpile for many things, including our personal protective equipment, visors, aprons. We had to ensure accessibility to a diversified type of critical or high demand supplies. And also we needed to have a crisis-ready supply chain, particularly for drugs. And because of a lot of effort from the operations side, we were able to ensure that we never ran out of the critical drugs that we required. During the COVID-19 crisis, we had different phases. One was DORSCON Orange, when the crisis first struck us. Circuit breaker is a concept I'll introduce a little bit later about what the Singapore government did. And you can see that consultations within the cancer, this is blue line is 2019 statistics for consultations in the center. The orange line is 2020, and you can see consultations went down. But right now they've recovered back to normal. The only thing is that some of these consultations went down because the patients were asked not to come, and we just renewed the prescriptions for some of the patients. However, chemotherapy wasn't that much affected in terms of chemotherapy load, and even right now is practically back to normal. And that is because a lot of the time chemotherapy cannot be deferred, although to some extent it was, but not as much. Radiation therapy also cannot be deferred most of the time, so the impact of it was a lot less. And in terms of imaging services, there's been some impact in the early phase, but now it's almost back to normal. And during this crisis, it was important for us to communicate not just with our staff, but also externally with patients, caregivers, and the public. Internally, we had to engage, we had to inform, we had to empower, we had to rally our staff and connect our staff. Externally, we had to update our patients and caregivers, assure them on stringent measures. In fact, I really felt that it was actually safer inside the center than outside the center because of all our stringent measures. And we had to educate on the processes, for example, drop and go and our medication delivery services. For example, patients coming to the center do not have to wait for a prescription. they'll just drop off their prescriptions and then they can go home and the medication will be delivered to their home. Education and training was important, and we had infection control refresher training, contact tracers being trained to use multiple electronic systems, contextualizing personal protective equipment guidelines for our cancer center use. There was constant vigilance, the use of split teams, such that some teams were at home, working from home to prevent staff fatigue and burnout. Research, I'm gratified to say our researchers played a significant role, even though a lot of the research had to stop. And many of them were placed on rostering duties in our triage and ushering. Many of them were serving at the dorms and the expo. Many of them were supporting Ministry of Health epidemiology unit. And our research staff adapted to the new norm by having split team arrangements, Zoom meetings, a decrease in social interaction with colleagues, and working from home. These are some of the publications that our researchers had during this crisis. These are just a few out of the 20 that they published pertaining to COVID-19. And it's very interesting that we published this because we didn't have a single case of COVID-19 actually to talk about. But these are really about our measures taken to prevent COVID-19 from happening within our center. And these are some of the innovations within our healthcare cluster that we were glad to be a part of. One of our surgical oncologists actually developed the SwabBot robot that can help do nasopharyngeal swabbing to test for COVID-19. It's an automated, comfortable process. Dr. COVID is a multilingual AI-based chatbot for which patients can converse with in multiple languages, and this is, I think, in Bangladeshi. There's also a swabbing booth to protect healthcare workers from being infected with COVID-19 when they swab patients. Wireless stethoscope. This is a TAMI robot that we use for telepharmacy, psychotherapy, and telecounseling, as well as other innovations. I'm going to next show you a video on the TAMI robot, as it was announced in the news. I hope the sound gets through, but if not, well, I think sometimes the picture tells 1,000 words. So in the next slide, you will see a video on the TAMI robots. Hang on, I think I'm not hearing the sound.
Minimize physical contact between patients and healthcare staff during the COVID-19 pandemic.
Okay, maybe you can't hear the sound.
Called TAMI,
but this is
12
basically the robot
remote-controlled robots are based
being
at
deployed
Sengkang
at
Community
our
and Bright
hospital.
Vision hospitals. And the
You can
expo
see
to
that
carry
it
out
helps
various
our staff to be
functions.
able to
The
enter the
interactive robots
COVID-19
have video
area without
screens
getting
and
infected
call buttons to
through the
allow
robot.
for
So you can see the
teleconsultations,
patient interacting with the
telepharmacy,
robot,
and
and on the
virtual
robot's
counseling.
face is
And this
actually
cuts down physical contact between
staff
patients and
talking
healthcare
to the
staff.
patient.
It reduces exposure to the coronavirus and
And
helps conserve
this is
a limited supply
instructions
of
about
personal
pharmacy for
protective
the
equipment
patient.
for
And
doctors
the
and
robot
nurses. They
acting
can
on
also
behalf
act
of our
as a
staff serves as
translator.
an avatar to go up to and chat with the patients as well. We also have a study looking at the psychological aspects of cancer care, or cancer patients, caregivers, and healthcare workers. And the main conclusion is that fears and anxiety were high, but levels decreased with higher levels of education. And burnout among healthcare workers is similar to rates reported pre-pandemic. These are some of the emotional support that we provided to our staff, encouraging them with gifts, encouraging them with many things to help them see through this crisis, including many memos and talks to help them cope and give them information, because education was important. And our staff was also deployed out to external operations, and we continued to stay in contact with them to encourage them. I would say that many of the measures we did would not have been successful if not for the measures that the country took. This is the Singapore circuit breaker. And as you know, a circuit breaker works when too much electricity is applied to current, and the circuit breaker trips, breaking the current. So that is our way of dealing with COVID-19. When there was an increase in number of cases, circuit breaker kicked in, and many services were stopped. However, essential services was continued, for example, health, social and selected care services, energy, petrol, gas services, and so is some public and private transport. And people could only leave the house for very, very particular reasons. And thanks to that, we are now come out of this circuit breaker, past phase 1 of safe reopening, and right now in phase 2 of safe transitioning, and waiting a little while before we go into phase 3 as we look at the international situation pertaining to COVID-19. So with that, I really like to thank you on behalf of the National Cancer Center and really appreciate your time listening to this talk. Thank you very much.
William Fong for the very comprehensive presentation. Actually, we have so many questions for you, but we have to discuss at the end of this session. I mean, after we have the presentation from Professor Tomihiro Matsuda, PhD. Thank you very much. We something like running late of this time, but we have to follow all of the session. Now we enter the third speaker, Professor Tomihiro Matsuda, PhD, will deliver about the cancer screening and palliative care in NCCP in Japan. Professor Matsuda, working in National Cancer Center Japan, then also as the president of the International Association of Cancer Registries International Agency for Research on Cancer. Then he also has the many international publications as the epidemiology cancer research. For Professor Tomihiro Matsuda, PhD, the time is yours.
Okay. Thank you very much, Chair, for your gracious introduction. I'm very honored on behalf of the National Cancer Center Japan to give this lecture to all of you. Okay, I hope that my speech gives you some pointers to develop the cancer care plan in Indonesia. Here we have a cycle of effective evidence-based cancer control. The first thing we need to do is to understand the current status of cancer in the area. So this is again the role of a cancer registry or some monitoring system, just like vital statistics or the death certificate. And the next step is to explore and adopt already proven cancer control measure to reduce the cancer burden. Then we have to actually intervene. Today, I'm going to focus on cancer screening and palliative medicine in this context. This is a diagram of cancer control measures currently underway in Japan. So it has started since almost 5 years. And early detection, cancer screening, and palliative care are clearly stated and positioned under item 1 and item 3, respectively. So this diagram really looks like the one of Indonesia. So we are kind of heading for the same goal. The first topic is cancer screening. Of course, it is the most important to prevent cancer. If we do not have cancer, it is kind of best. But while it is very important to maintain and continue on living a cancer-free lifestyle, some of the cancer is preventable, just like lung cancer, cervical cancer, or the other cancers, which is strongly related to the lifestyle. But not all cancers can be prevented 100% of the time. If you do get cancer, you can still get effective treatment by detecting in early. This mechanism and the system is called the cancer screening. I quoted the matrix from the World Cancer Research Fund, and it shows the evidence-based cancer prevention method or the evidence-based cancer risk factors according to the lifestyle and according to the primary site cancer. Firstly, I briefly explain the cancer screening status in Asia. Population-based, it is called organized cancer screening. It is different from the opportunistic kind of volunteer-based cancer screening. And this population-based organized cancer screening program have now been introduced in my country, Japan, Korea, Taiwan, and of course in Singapore and Thailand, and beginning in China. I had that. And this organized cancer screening is different from the opportunistic one because it is for all the population, all the general public living in the, designated area. Hopefully it can be the whole nation. And the opportunistic cancer screening is the one who want to have cancer screening go voluntarily to the health institute to undergo a cancer screening. So this is the completely different action. And Korea is very well known for its comprehensive cancer screening program. It is called the Korea's National Cancer Screening Program. And it has been in place since 1999 and target gastric, liver, colorectal, breast, and cervical cancers. I continue this topic of Korea National Cancer Screening Program. And medical aid program recipient and the national health insurance beneficiaries in the lower 50% income bracket are eligible for free cancer screening. So they guarantee cancer screening for all the people, even they have no kind of low income. We have to be very careful about the cancer screening. The general publics and even the medical doctors tend to have an illusion about cancer screening. For example, many people believe that the cancer screening is perfect. It means if we undergo the cancer screening, the 100% we can detect the cancer in early stage. But there are always the false positives and false negatives. Of course, in the future, maybe we can find some kind of measures to detect cancer completely 100%. But according to the current technology, it is not possible. And the risk will reverse over time. Screening can be harmful. It is sometimes invasive, so we cannot recommend freely to have a cancer screening. And delayed treatment for false negative individuals, unnecessary testing for false positives, complications, and diagnostic treatment for clinical meaningless cancer compared to life expectancy, etc. So we really have to be careful and we have to understand what it is cancer screening before we introduce this system in the country. That screening and cancer treatment is completely different. Maybe you will understand according to the graphics. That screening is for healthy people who have no problems in their lives eligible. It means that people who have already the symptoms, it is not cancer screening anymore. It's treatment and it's health examination. Screening is regularly provided for the general public who has no problems and no symptoms. It means the low prevalence of disease. So it is more important not to misjudge a healthy person as patient than to diagnose the disease correctly. And the test must be inexpensive. It has to be a kind of minimum of cost and minimally invasive. On the contrary, cancer treatment and cancer examination is for people already with symptoms for example, the stomach ache, headache, or the bleeding or something, and that interfere with their lives are included. Therefore, the proportion of people with a disease, here it is cancer, is very high. So it is important to diagnose the disease, the cancer, correctly, and even clinically invasive and expensive tests for medical intervention are allowed to some extent. Okay. And in addition, there are 3 steps to effective cancer screening. If you don't climb these steps one by one, your cancer screening will be completely useless. So firstly, you have to apply the evidence-based cancer screening methods, and then you have to control the quality of cancer screening. And then after, you have to improve the screening rate. In many countries in Europe and the United States, the breast, cervical, and colorectal cancers are covered by the organized cancer screening program. But in Japan and in, for example, Korea, the following 5 sites are recommended by the guideline. So we add the stomach and lung. I heard that in Korea, they do a liver cancer screening. And it is not scientifically acceptable to perform cancer screening at other sites, age, and intervals, because they are based on the scientific evidence that they reduce the mortality rate. So in this context, some medical doctor believes that if you do, for example, mammography breast cancer screening for example, very young age women, 20 years, and they believe that the cancer screening is not harmful. It's always kind of beneficial, but it's not that. It's harmful, and it has a lot of kind of negative aspect. So we really have to respect the age which we introduced the cancer screening program and interval. So we decided it's 2 years. If not, it's completely harmful, and it costs expensive in the society. Once you've conducted scientifically meaning cancer screening, the next step is to manage the quality control. There are many indicators I listed in this graphics for managing the quality of cancer screening. Among these specificity and false negatives, they can be only calculated by linking cancer registries and the cancer screening list. Yeah, this one. So the cancer registration, my measure, is very useful for the quality control of cancer screening programs. Evaluate the quality control, quality of the cancer screening is kind of countermeasure the type of medical examination. We have to calculate sensitivity, specificity, false negative rate, false positive rate, etc. Of course, the first step is to provide the cancer screening for all the people, even they are poor, even they are living in very far from the cities. But we have to survey or monitor the quality of cancer screening. If not, only the provision of cancer screening programs, it doesn't mean, of course, it's a kind of first step, but it doesn't mean a lot. So case studies on the false negative cases and false positive cases are also important. We have to carry out and why we missed, for example, one cancer by X-ray or the mammography, etc. And then we have to improve. We have to stop if there is kind of problems, or if there is some kind of barrier to detect the cancer correctly. And this procedure is carried out regularly in European countries. research conducted by Dutch researcher, the Sabine Sisling is our kind of very kind of cute colleagues in cancer registry, has kind of shown that about 80% of population-based cancer registry in Europe have this quality control in place, and half have it in place on a regular basis. So we really have to do this quality control measures regularly. As I told you, the cancer registry can serve a variety of roles beyond simply calculating incidence and survival rate. And in this way, can be linked to other databases, cancer screening database, or we can use cancer registry data for some population-based survey, like cohort study or anything. And we can add in the future, for example, biobank data or health insurance claims or any clinical survey data, which is sometimes the patient-reported outcome, the quality of life, etc. But to realize quality control by linking population-based cancer registry and cancer screening list is not so easy. Handling personal information, we have to be really careful, and data linkage is sometimes difficult. I think in Singapore or in Taiwan or South Korea, they have this PIN. It means personal identifiable number. But in a country just like in Japan, we have one, but we cannot use for the medical topics. We really have to use nominative information. It means the name and surname, birth date, address, and it is not efficient and not accurate. We really have to develop and really have to improve kind of utility of such kind of ID number in the country, even to control the quality of cancer screening. Okay. And then the next step is to increase the screening rate. It means we ask the general public to go to the cancer screening. Although the cancer screening rate is increasing in Japan, it is still not high enough compared to other countries. In other countries, I think it's almost 80%, 90%, but in Japan, it's still under 40%. I think reasons for not taking cancer screening in Japan are not the kind of the economic reason, but simply they are kind of ignorant of the importance of cancer screening, or they have fear of finding out the cancer. And embarrassment, for example, for women to undergo breast cancer screening or cervical cancer screening. I think we share the same culture in Asia, so to make people go to cancer screening, we can cooperate with and to overcome this barrier and step. The measure of cancer screening is cancer mortality rate. The evaluation should be done with the cancer mortality rate, not survival rate. Some clinicians claim a high survival rate for cancer patient detected by cancer screening, but this does not mean that the cancer screening is effective. One example I show here in this graphic is lead time bias. If you find cancer in early stage, but if there is no symptom or no can harm influence on their life, we can leave this cancer for a while. And even we detect the cancer by symptom, if this patient lives longer, as long as the patient can his cancer or her cancer detected by screening it means this cancer screening program is useful. It doesn't mean that it is useful. So we really have to evaluate the effectiveness of cancer screening by cancer mortality. So, for example, the OECD, they check the cancer mortality rate on the same page of the cancer screening rate. But oops. This seems to be true in, for example, in Spain. I underline in green. It means the Spain has a very high cancer screening rate in mammography. And at the same time, the breast cancer mortality in women is comparatively lower, but not in Japan. So in this case, it shows kind of complexity of cancer control. It does not link one-to-one. And it means the low mortality has a lot of kind of the factors, not only the cancer screening program. Okay. And then the final barrier after climbing the 3-step, maybe the mass media. If mass media has lower health literacy, they can mislead the research result or the result of quality control to the general public. And even in Japan, when we publish the result of quality control of cancer screening program, and they reported completely in the wrong way. So we have to have, for example, the mass media meeting, and we have to improve their literacy to educate the general public through the mass media. Okay, it took kind of long time. And now the second part, palliative care, it is comparatively short, so I can finish soon. Principle of cancer treatment is that now it is almost kind of standard to use the combination of surgical treatment, radiation therapy, and chemotherapy. And before, the palliative care tend to be used in the the final stage or late stage of the cancer patient, the treatment path. But now, today, the palliative care tend to begin early in the cancer diagnosis. It means even just after the diagnosis, the medical teams try controlling their pains or their anxiety or the anxiety of the cancer patient family. Okay. This is a definition of the palliative care, WHO. The palliative care is an approach that improves the quality of life of patients and families facing the problem associated with a life-threatening illness. So it doesn't mean to, to improve the quality of life of the patient who is going to die. So the hospice is not equal to the palliative care unit. The word hospice is used interchangeably with the palliative care unit. And the main goal of palliative care unit is to control pain and life as normal as possible. On the other hand, the main goal of hospice is to live as desired until the end of life. So the notion of palliative care, of course, before it was the hospice, the patient who go to die without pain or without any anxiety, but the palliative care, it covers the whole life of the cancer patient and survivors. And in the safety and comfort of your own home, you can receive the same palliative care you receive in a hospital while being able to adjust to the pace of your life. This is kind of the concept of home care and treatment at home and survivorship. Early detection and effective standard of care have led to a higher survival rate for cancer patients. And the combination of less invasive treatment that maintain quality of life, palliative care, and home health care has allowed patients to reintegrate properly into society. And as Singaporean National Cancer Center, we have also this outpatient treatment center and supportive care center and palliative care ward in the hospital. Okay, I conclude as summary, the scientific promotion of cancer control measures required understanding of current status by mainly by a cancer registry, and the implementation of measures tailored to one country's situation according to the culture, according to the society, and the evaluation of these measures with quality control. And we have to be aware of this kind of cycle at every stage of cancer control, and no step in the cycle should be neglected. And so cancer registry or cancer statistics is kind of base, and we have to pile up the cancer control measures on that. And we really have to step by step to promote cancer control program in the country. Thank you very much for your time.
Presentation, Professor Matsuda, then we know that we can learn so many things from your presentation, and also from your center. For the next 20 minutes, we will have a discussion, or we will have something like question and answer. Then the question will goes to both of you, or the three of you, Dr. Suko or Professor Huang, and also Professor Matsuda. The first question that's about the tumor board. How the hospital or the cancer center develops the MDT? How the system? Then also the system they work. If the tumor board talk about or discuss about all cases, or only the specific or difficult cases comparing the clinical pathway. This is for the tumor board. That's the question for both of you. Maybe Professor Huang first, you would like to answer the question? Thank you. Dia enggak, itu masih di mute. Still di mute.
Sorry, yes, I will try to answer this question. During the last few minutes, I prepared some slides, which maybe I'll share in order to guide my answers a little bit. So you were discussing about the tumor boards, and one aspect is that it's true that there are many cases, far more cases that we can discuss. Usually the chair of the tumor board will make a decision, or the deputy chair, whoever is deputized to make the decision in his place. The main idea of the tumor board is that when it comes to a complex case, we can sometimes rely on the tumor board to some extent to have a little bit of legal protection pertaining to difficult cases where the treatment modality or the treatment type is sometimes not so clear or not so obvious.
Yeah.
Then in that case, the tumor board gives us the ability to discuss cases for which the right approach is not so clear. So the chair will make a decision, and sometimes the person presenting, who wants to present the case, might say that I really want to present this case because I would like to get a consensus from my peers on this. This is true, not every case is presented, although some tumor boards will just quickly run through some cases to just say that, okay, this one doesn't have to discuss, you can present, but we don't have to discuss, and so on. I have some other questions I saw on the thing, and one of which pertains to palliative care. So I'll quickly answer this, pertaining to the introduction of supportive care. Traditionally, palliative care starts here, when the patient is, getting a little bit more terminal in terms of his treatment. But sometimes you can still introduce supportive care at an earlier stage. And patients have various symptoms. They have pain, they have vomiting, they have inability to eat. And certainly some of the expertise from our palliative care professionals can be extended to our general medical oncologists in order to ensure that patients are looked after, not just in terms of curing them, but also in terms of treating their symptoms. And that's the reason why we extended to have supportive care programs to not so much that the palliative care professional delivers it, but the palliative care professional teaches our general medical oncologists to deliver good symptom care and good symptom management. And this extends beyond death of the patient to in bereavement care. Another question was pertaining to training. And we, as you can see, the National Cancer Center runs this Asia Pacific Hospice Palliative Care Network. And we kind of try to, you don't see our name anywhere else except here. So we try to keep very much in the background in this. And there are many resources here pertaining to education that palliative care professionals can join as well. But in terms of palliative care training, we are part of this Lien Center for Palliative Care, and there are courses for doctors, for nurses, and allied healthcare professionals. And you can Google this Duke NUS Lien Center for Palliative Care. You can see various courses for palliative care for different types of professionals. Another question I saw was pertaining to where does Singapore sit in terms of this cancer preparedness. I actually have seen this document before, and I tried to Google for Singapore and couldn't find us. I think it's because Singapore is much too small, and maybe the economists may have just ignored where we exist. So I actually don't know where we stand in terms of this, but our cancer incidence rate is not small as well. So in that document, I actually don't know where Singapore sits. But however, the National Cancer Center was recently ranked by Newsweek to be one of the 100 best cancer hospitals in the world, and it's the only one in Southeast Asia. Pertaining to payment for patients in Singapore, I would say that if a patient is a Singaporean, I have no worry. And if the patient is a Singaporean being treated in a public hospital, I have no worry for the patient, because there's always a way that the patient can access. It is the patient may have to speak to the social worker, the patient may have to give some information about his assets and his wealth and stuff like that. But I've never encountered a Singaporean having a challenge in being able to pay for bills for a treatment that is truly indicated. Now, some treatments may be uncertain as to whether they are indicated, and some treatments may be still not yet approved in terms of their indications. But otherwise, for Singaporean, it's not a problem. Now, for a foreign patient, there are significant challenges because I cannot tap on any of these subsidies for foreign patients, unfortunately. So that's all I have to share, actually. Thank you very much.
Of the question for you, but you still have one or two questions that we will discuss after Professor Matsuda. Maybe you would like to deliver your conclusion about the question. Tolong dibuka dia punya.
I think he's muted too.
Yeah.
Okay, thank you.
For the answer to the same questions for the cancer board.
Yeah, about the how the tumor board in NCC, how the I think how many, and then how the case will discuss in the term of the cases.
Yes, so it's almost the same as National Cancer Center Singapore. So it is, I think, since more than a decade, this team medicine or team treatment is very standard for the cancer treatment. It means not the direction is not decided only by the medical doctors or only by some specialists, but it includes, of course, nurses and, of course, for example, the social workers, and we include, of course, the patient and patient family. I think a long time ago that the medical treatment was mostly decided, mostly recommended by the medical doctors. But now it's from the beginning, the medical doctors or medical teams ask the patient and ask the patient family's preference. If they refuse completely, of course, the medical doctors persuade them to undergo the scientific or the modern treatment. but they still try to hear their preference. And if, for example, they prefer to stay at home, they make the kind of maximum effort to follow their request. And this is also the same thing for the cancer control program in the nation. Before, this cancer control program is defined by the politicians or defined by the workers in the health ministry. But now in the committee, we invite the cancer patient and related, for example, the member of some associations related to the cancer treatment, and not only by the medical specialists and the politicians. So the direction is kind of coherent. We try opening the decision-making process to the general public and of course to the patient. And this is also kind of the concept of tumor board, and not to decide by the only kind of few specialists, but by everyone, because the cancer is the disease for the patient and disease for the older people. That's all. So, and the structure is, I can repeat the same thing. So it's almost the same thing in the National Cancer Center thing.
Okay, thank you. Second question, that's for the NCC Japan, that from your data, looks like the cancer now, current situation, it's getting younger. Then how about the age, compulsory age for the first screening? For instance, for the breast cancer or for the cervical cancer, for others, that's the high in the other countries.
Okay, so for example, the breast cancer, we recommend that woman who has the 40 years to come to the medical institution to have cancer screening. And we know that, for example, in the States, United States, it is 50 years, or in the other countries, kind of 50, or sometimes it's higher than the 50. And yes, we know that. So just like in this kind of tumor board, we are always discussing if we, for example, change the method, or if we change the start age or the interval. And for example, stomach cancer or colorectal cancer, once you have endoscopic examination, some specialists say that we do not have to repeat this kind of endoscopic examination every 2 years. For example, 5 years is enough sometimes. So we really can discuss always, and it's kind of very flexible to change this kind of the age and the interval, and even the methods. Before to do a stomach cancer screening, we use only the X-ray, but since 2 years, 3 years, we add this endoscopy examination. So it is according to this kind of evidence and according to the other countries' decision, we change it flexibly. So it's not kind of fixed in the one. And I cannot say every year, but in 2-3 years we change, and we try to do our best to organize cancer screening.
Then the next question is about the clinical pathway, about the rule or the rule of the NCC in making or evaluate or updating the clinical pathway. How many years the term of the clinical pathway itself we update it, and how the rule of the NCC in the term of the clinical pathway for the cancer cases. Maybe Professor Huang, you first would like to answer the question?
Sure. We have clinical pathways developed for within the cancer center itself. It is a little bit more of a challenge to say that the clinical pathway should be adhered to by everybody else. But because we are part of a healthcare cluster and we have recently develop cancer service lines that stretch throughout the healthcare cluster, including at the different hospitals. We now have the ability to have common pathways throughout the entire cluster. But I would say that it's not so easy. It takes a little while. It takes people to discuss, and people have different views about different pathways. But fortunately, there are many international guidelines that we right now are able to fall back on. For example, the NCCN guidelines, as many of you are familiar with, allow us to fall back on in the absence of a very clear pathway that is agreed upon between everybody else.
Is there any something like every 5 years or every 2 years according to the evidence base or something like that for the updating? For instance, like we in Indonesia, knowing that we haven't had any human resources to develop that, so that's why we adopt from NCCN from US. So we sometimes trying to update it or making that according to our situation.
Yeah.
In Singapore.
I think it's a big challenge because even for the NCCN pathways, every year or so, they need to change. And you really have to be able to be on top of the literature for each cancer subspecialty, whether it's myeloma, lymphoma, lung cancer, liver cancer. And there are many different aspects to stay on top of. So I do confess that we also rely on NCCN guidelines quite a fair bit. We did have some crafting of best practices, which we submitted to our Singapore Academy of Medicine journal before, but because the guidelines keep changing. So what we try to do is to at least have a cancer center best practices, some general guidelines pertaining to when it's appropriate to investigate, when it's appropriate to do certain scans. And a lot of this has to do with cost control in order to manage costs for the patient.
Okay. What do you think? Professor Matsuda, do you have any opinion about that?
Yes, the idea of clinical path is already introduced in Japan since a long time, but recently the academic association did a kind of survey on how often you use kind of standard clinical path in medical treatment in your hospital, and it was kind of almost 30 or 40% of the cases. So it means all of us understand the kind of standardization or evidence-based the cancer treatment, but in real kind of clinical setting, it is sometimes very difficult to follow the clinical path. I don't know the real reason, but sometimes it's kind of the bureaucratic reason, and medical doctors, they do not believe sometimes kind of standard procedure or the guidelines. But in some cases, the cancer patient, the clinical path has kind of its limit, and even we follow the clinical path, it cannot, for example, improve their health status. So they change the management of their cancer treatment. So we still try, but just like cancer screening program, it's not kind of 100% omnipotent and perfect. We really have to improve clinical path and our mind to standardize and to improve cancer treatment in the country.
I can only say that this is something that we are kind of still working towards. Singapore has a large movement towards value-based healthcare. Value is outcomes over costs. And we don't always talk about cost, but also outcomes. And sometimes just analysis of different practices and showing to the doctors what is their outcomes versus the costs taken does influence behavior to some extent. And value-based healthcare, the greatest lever actually, which is what the Ministry of Health is trying to do, is that we will base on the recommendations to decide what we will pay for. And if nobody is going to pay for it, you will find for certain practices, you'll find the practice will change based on the payer holds the most power.
I mean, do you think this is need something like consortium to talk about this in the country? For instance, like us, we don't have any human resources, that we need people talking about this.
Yeah.
Talking about this, the consortium for that.
Yes.
The review of the NCCN.
I think the consortium is important to address specific questions, but in truth, to replicate what the NCCN is doing as a whole is very, very difficult for all of us. So I think let the NCCN do what it does, but we need to address specific questions pertaining to specific issues in our different contexts.
Yeah. Do you have any idea, Professor Matsuda, about that, about the consortium? Is it need for the something like evaluate of the NCCN in the country?
The consortium in the country or in each region?
Yeah, in the country, something like to look, to see is it still something like valuable, or about the cost and about the treatment itself? For the consortium, evaluate or updating about the NCCN in the country.
Yes, we have the NCC Consortium, NCC Association, and it connects all the designated cancer treating hospitals. And we have a lot of hospitals compared with the other countries. And we designate almost 400 cancer treating hospitals in the country. And but it is only exchanging the information, and this association, this consortium does not have real power to promote, for example, the clinical path or any, I would say, the guidelines. We really rely on each hospital, the liberty or their way of treatment. So of course that we try and standardize and improve the cancer treatment within the consortium or association. All the hospitals are independent, and sometimes they do not really listen to the decision of the one association or one consortium. So it's not so easy, but the network consortium, it has some meanings. So I recommend you to link all the cancer treating hospitals in Indonesia.
Okay, thank you. That's the last question, but not least. This is about the mentoring or coaching to the hospital or cancer hospital in the country. Since now, Indonesia already has the National Cancer Center. Now the government or Minister of Health point out us to telementoring of the 14 National Cancer Center in the country. Do you have any something like experience about the mentoring of the cancer hospital in Japan? Yeah. Professor Matsuda, maybe you have the experience to share with us.
Mentoring, or we organize training course for such workers in designated cancer treating hospitals. For example, the staff working in now it is compulsory to set up one station for the consultation of the anxiety or how to reintegrate in the society for the patient. And we organize the training course for the staffs who working in the consultation station in the cancer treating hospitals. And of course, the treatment or the nurses who will take care of the cancer patient. The National Cancer Center organized nationwide the training course for the medical workers and the consulting staffs working in the cancer treating hospitals. So this can be a the way to mentoring or to educating the cancer hospitals in Japan. But as I told you that it's not so, it does not have the authority or power. So we just provide the information and education, and their practices can really independent. So we do not know if they really follow our education or our indication.
Okay. Yeah. Thank you very much for the very informative presentation. Then now I think we already reached
Ada satu pertanyaan dari
45 minutes.
habis.
Yeah, because this is already run out of time. We would like to thank for the our distinguished speakers from NCC Japan and from NCC Singapore. We hope we will have the next webinar. Then we would like to invite you also as the speaker in the new or in the later topic. Then now we would like to take a pictures as usual first before we end of the session. Please open for all of your video, for all of the untuk seluruh peserta mohon
Foto
dibuka.
bersama.
Pak Wira, terima kasih telah hadir. Pak Bambang,
Wira,
terima
Bu
kasih.
Okti.
Bu Okti, terima kasih. For speakers, Bu
Ada
Liz,
Dr. Khalid nih di Ruth
terima
Wahidin.
kasih. Mohon dibuka untuk kita mengambil foto bersama. Thank you very much for Professor Wang because he would like to leaving earlier because this is already run out of time.
Terima
Please
kasih, Prof.
smile.
Kadir.
Terima kasih Prof. Kadir.
Terima kasih.
Ya, just smile Prof. Kadir. Terima kasih. Ibu Ning, terima kasih. Baru satu kali, mohon senyum dulu. Prof. Suko, Dr. Suko, terima kasih. Terima kasih. Di sini kami tidak membuat kesimpulan karena masing-masing telah mendapat informasi yang sangat lengkap dan kami sangat berharap kita dapat mengikuti webinar dari Rumah Sakit Kanker Darmais Pusat Kanker Nasional yang akan terus membuat rutin webinar dan kami sangat berharap mendapatkan komunikasi dari seluruh peserta maupun para direktur, para kepala dinas ataupun pemerhati kanker, survivor dan seluruh asosiasi maupun foundation yang hadir pada hari ini. Kami mengucapkan terima kasih atas waktu yang diberikan. Thank you very much for Profesor Matsuda, Profesor William Wang for your sharing precious time and presentation. Thank you very much.
Thank you.
And see you again
See you
in the
again.
next session.
Terima kasih Pak Wira.
Thank you. Bye-bye.
Bye-bye.
you, bye-bye.
Thank you. Terima kasih Dr. Yusuf, terima kasih
Terima
Pak
kasih.
Tommy, terima kasih
Dr.
Dr.
Vines.
Grace, Dr. Vines,
Dari RSHS ada
dari
Pak Denny.
RSHS, dari Rumah
Karyadi
Sakit
ada
Karyadi,
tadi.
terima kasih.
Pak Artanto Wahyono.
Dari Wahidin, terima kasih Rumah
Dari
Sakit
Sanglah tadi juga ada.
Sanglah,
Husen,
Husen,
main golf Pak.
terima kasih untuk Samarinda.
Ini dari mana nih? Muhammad Husen.
Kami mohon pamit, terima kasih untuk waktu yang diberikan, mohon maaf untuk segala kekurangan. Terima kasih, terima kasih.
Terima kasih.
Dari Ketua. Terima kasih Dr. Christine,
Tercipta ada.
Dr. Cita, Dr. Dik, terima kasih Dr. Nurwati untuk pertanyaannya, Maria Wisaksono, Dr. Dita, Direktur MRCC,
Alhamdulillah akhirnya.